you know, if questions come up, you can ask. Nice hairstyle. Yes, so my hair is very messy. As usual. Although we got some pretty good beards on the call here, man. Nate's growing it out.
Get some grays in there, Nate. I love it.
I do. I've got a gray goatee hiding in my beard. Great.
I'll be honest, I started doing some gray for men over the corners here. Keep it. Once you start, you can't stop. That's the problem.
So for those of you just logging in, we're just kind of hanging around with our group of panelists, just shooting the breeze while everyone gets to just take a few minutes for everyone to log in here. So thank you for joining us. Maybe while we're chatting, and it's nice to see you got people from Brazil, Bangladesh, Uruguay, Venezuela, Boston, Spain, Uganda. Wow, fantastic! Lithuania.
There you go. That's for you, Mitch.
Albania, France, Libya.
Nice.
Barbados.
Wow.
Turkey, Israel, Saudi, Panama. Look at that. More Venezuela, Spain, France, Brazil, Arkansas, Buffalo, Salt Lake City, and from Nikki's studio.
Oh, Quebec.
From Quebec. Hey, Marjorie's here. Marjorie, we're actually, Marjorie, I'm going to actually make you one of our panelists. I'm going to make that decision right now because I realize we need some diversity. Yeah, we need some diversity here, man.
Yep.
We're mantling out.
Oh my God. Ravi Gold is going to kill you, Jab. Ravi's going to say, what is with this mantle? Marjorie, where are you? I hope you're able to join us, Marjorie.
In here.
Maybe.
Oh, we've got Sahar also. Maybe we can get her.
Who's that?
Sahar Bedrouk. Get her in here.
Oh, okay.
What's up, Sahar? Yep.
Okay, we're getting Sahar. Sahar, you've been promoted here. Although well.
Josh has his hat now.
Nate's gonna serenade us, it looks like.
No, I wanted to put that there for you, Paul.
Now I feel better.
Yeah.
Now I'm more relaxed.
So Marjorie just said that she doesn't look good on her camera. Okay, well, listen, I mean, I want to get started here. We're just kind of talking a bit while people are joining us. We've got a couple hundred people, which is great to see. We're going to get started in just about a minute. And actually, while we're starting here, let's just kind of go around a bit. We were talking about glaucoma in New York and about COVID. You know, so let's get Nate. Nate, you are like literally in the hotspot of the world right now. Like you are, sadly to say, that's kind of where the big hotspot for Corona is right now. What's going on, man? I mean, what's going on in New York? What are you doing? What's happening with the glaucoma patients?
Yeah, I am personally shut down, and I've got a very busy severe glaucoma practice. We had a couple of ophthalmologists in our practice get COVID, and we closed the office. Academic centers are still open for emergencies. You know, I'm sitting around being thankful that I treated a lot of people with SLT over the preceding months. And I think a lot of these emergencies are just going to have to be dealt with at this point in time with Diamox and deferral. There are some monocular patients, and we can find people who are still operating, but it's just you have to ask every question. Every patient has to be asked the question: is this worth risking your life to even bring you in for a visit? Because so many people, so many physicians, we have ophthalmologists on a ventilator as we speak. The risk is just exceptionally high. Everyone's affected. And so you just have to ask yourself, am I adding to the problem by just taking someone out of their house? They're going to get a cup of coffee, they're going to get on the subway, they're going to get an Uber to come see you. And the likelihood of some bad coming from that is palpable.
Yeah, I think that's kind of been our philosophy as well. I am surprised though. I do see different pockets of people working. Not to judge, of course, but I think it probably depends on how bad things are in your area. But sometimes, even if it's not bad in your area, it's going to potentially get there. So we've been taking a lot of precaution as well. I don't know. Let me ask who else is here. We got. How about you, Paul?
Yeah, I mean, we're the same. I just opened up for a few urgent, or I've done like 2 surgeries now in the last 3 weeks. And some patients who are, again, monocular, pressure in the 50 or 40s and on meds. But yeah, we tried to really furlough most of our staff, and we're just kind of keeping a skeleton crew, waiting for some of the stimulus money to come in, hopefully the next couple of weeks, like everybody else, I'm sure. And I think the key is just trying to maintain our skeleton crew, maintain our staff in our office as best we can. And then the guessing game, I think, what the stressful part of this all is when is it going to start up again? When can we? Because we can't plan, financially, or even just from taking care of our patients and serving them. When is it going to come back? So we're doing some telemedicine. We're using the, speaking of hysteresis, we're using the Aura machine to help them, if I'm right, to help do some IOP checks for those who are really, really urgent, I want to see. And my techs do that, and I'll just do a telemedicine consult if I have to. But those are far and few between.
Yeah, I think a lot of us are doing that as well, virtual care. And it's really hard to do it, of course, in ophthalmology, but especially glaucoma. But there are patients who have eye problems that we can handle a little bit that way, and we've been trying our best to manage those as much as we can. Okay, I was just trying to get some. I just picked up some panelists here. I see some of you are on here, and I'm sorry to pick on you, but if Mariam and Sahar, and I guess Marjorie can't, but if you guys are welcome to join us. We'd love to have you on the panel group here. We really want to get out of the mantle here that we're in right now. So if anybody wants to volunteer, we'd love to have you. And we'd love to have you guys present and join us. So please do that. Well, I think we'll get started here, and I'm going to have Jeb maybe start off with some slides. We've been doing this now for a few weeks. It's been great. We've got about 300 people here today. We've had a nice time talking and chatting different topics and a lot of cases. I'm excited about the group we have here today of great speakers and panelists. I'm going to let Jeb introduce them, but just want to let you know again that if you're interested, please email us, because we do like to have varying opinions on these panel groups. Yesterday we had a special joint session with Ophthalmo University, which is a Latin American ophthalmic education group of surgeons, and it was a really big. We had a few thousand people actually out there, so it's incredible how big webinars have gotten. I think we're kind of webinared out almost with all the Zooms that are going on, but it is a great way to see everybody and connect, and part of it is what we do this way. Jeb, you want to just get things started? Jeb Long is our co-host and has been helping organize these rounds.
Perfect. So thanks everybody for joining us again. Welcome back. Just a few reminders. Our website is www.prismiinstitute.com/webinars. If you have any questions, comments, please send them to ike.webinars@prismi.ca. We've been getting quite a few emails. They're always very much appreciated. Let me just switch here. Great. So this is just a reminder again of the different types of formats that you can present if you're interested, whether it be a lecture, a case, or an article, which we actually haven't done yet in the last little bit here. So that'd be kind of interesting. Again, for any type of requests, if you're interested, please send an email to that email address that I mentioned. Just to mention also, we've been getting a lot of questions about these. These webinars are recorded. They're all going to be available on our website. That being said, it sometimes takes a few days before they get uploaded. And lately, we've been trying to upgrade our website as well. So that's kind of why some of the topics weren't up yet. So we apologize for that, but bear with us. It will be on soon enough. So I just want to briefly mention some of the presentations that's coming up. So for April 11th at 12 p.m., that's this Saturday. We do have quite a few interesting topics as well. So we're going to be talking about challenges of the day, enforcing iridocorneal distancing. Dr. Steve Safran is going to be presenting delicate and dangling, essentially talking about management of different challenging IOL cases. That's going to be very interesting. We're also going to have a retina specialist who's actually going to present no vitreous, no problem, cataract surgery in post-vitrectomized eyes. So again, be there. That's going to be very interesting. I think most of you will find that very useful. Okay, so first in our presentation list here, our first speaker is Dr. Nathan Radcliffe. He's an associate professor of ophthalmology at Mount Sinai School of Medicine and New York Eye Surgery Center. That's in New York. He's also in the Glaucoma Clinical Committee of the ASCRS. He's chief medical editor of Glaucoma Physician Publication. On his panel, he has Dr. Paul Singh, who's a glaucoma specialist at the eye centers of Racine and Kenosha in Wisconsin. He did his fellowship at Duke University, and he did his residency at Cook County Hospital. We also have Dr. Mike Greenwood, who's a cataract, refractive, cornea, and glaucoma surgeon at Vance Thompson Vision in Fargo, North Dakota. He did his residency at Case Western Reserve in Cleveland, Ohio, and he did an advanced anterior segment fellowship at Vance Thompson in South Dakota. And our second presenter is Dr. Guillermo Rocha, who's medical director of TLC Laser Eye Center, that's in Winnipeg, also of the Ocular Microsurgery and Laser Center. He's a medical staff in the Brandon Regional, Minnedosa, and Misericordia Health Centers. He's also a professor of ophthalmology at the University of Manitoba. He was the past president of the COS, and he's the current president of the COS Foundation. On his panel, he has Dr. Amandeep Rai, who's a comprehensive ophthalmologist here in Toronto with us. He's also the Associate Program Director at the University of Toronto, Ophthalmology Residency Program. Although of late, probably his biggest duty is actually changing diapers on his newborn baby. So we also have Dr. Alejandro Lichtinger. He's an Associate Professor at the Corneal and Refractive Surgery Department at the Instituto de Oftalmología. How's my pronunciation? Was that okay? He did fellowships in cornea, anterior segment, ocular surgery, and refractive surgery in Mexico, San Diego, and Toronto. And last but not least, we have Dr. Toby Chan, who's a glaucoma and anterior segment surgeon at the Ocular Health Center in Kitchener, Ontario. He's also co-division head of ophthalmology at St. Mary's and Grand River Hospital, also in Kitchener, Ontario. He's also an assistant clinical professor at McMaster University. And he has on his panel Dr. Matthew Schlenker, who most of you will probably remember from last week. He did an excellent presentation on OCT interpretation. He's a glaucoma, cataract, anterior segment surgeon at Kensington Eye Institute, Toronto Western Hospital, and Trillium Health Partners here in Toronto, Canada. And also we have Dr. Joshua Teichman, who's a cornea, complex anterior segment, refractive cataract surgeon at Prism Eye Institute, Trillium Health Partners, TLC, and the University of Toronto. Oh, I think we might have gotten hacked, guys. I have no control over that. And with that, I'm going to open up the floor to Dr. Nathan Radcliffe, who's going to be presenting on corneal hysteresis. If you go ahead and share your screen, Nathan.
Just while Nate is just joining on here, Nate, go ahead and you can go ahead and share your screen. I just want to bring on Sahar Badrood. Sahar, I see you there. Thank you for joining us from California. She's always had fun having Sahar part of our groups, and I just asked her right now, so she was kind enough to join us. So hi Sahar, how you doing? Oh, you're on mute, but well, you look like you sound as good as you look, so we're doing well.
Hey, thank you, last minute capsule.
Thank you. You're
all right.
Perfect.
Excited to join.
Thank you, and we have also Mariam Abtahi from Ottawa. Thank you for joining, Mariam.
Hi, thanks.
Thank you. Okay, great. So listen, here's what's going to work, everybody. We've got polling questions for some of our cases. We've got Q&A, and you can use the Q&A button, and then we have the chat. And I'm going to ask the panelists to please monitor the chat line. If there's something that comes up you think that's maybe worth bringing up, go ahead and interrupt or go ahead and ask. We try to make it pretty casual. We've got a really international group here. We've got about 320 folks here. So Nate, thank you for joining us, and you're going to share it with us about how hysteresis is helping you in your glaucoma practice. Well, maybe not now, but how it was and how it will be.
Previously, yeah. So right, this is corneal hysteresis as we used to do it, and hopefully we'll get back to doing things. I mostly focus on hysteresis apart from practicing in the COVID area, but there may be a few things that come up here. One thing that I did want to say is that hysteresis is a dense topic, and I want to get to cases. So I'm going to quickly review the literature, and I'm going to have to force myself to move kind of quickly through that because you could spend a lot of time on it, and we want to get to case discussion, and I want to hear from Paul Singh and Mike Greenwood on how we might manage some of these patients. I consult with a number of companies in this space, including Reichert. Suffice it to say, we all understand that corneal thickness is just a profound risk factor. And to me, I cannot think of managing a patient with glaucoma without knowing the corneal thickness, plain and simple. It's just, I can't get past that step unless I know the corneal thickness. And we know, for example, that having a thin cornea is much more powerful than having a high pressure in terms of glaucoma risk. Hysteresis, so corneal thickness is a geometric property of the cornea. Hysteresis is a behavior. To show you the difference between geometry and biomechanical behavior, I'm going to try to show you a video of two similarly shaped balls dropping that have different viscoelastic properties. And I think through the magic of Zoom, this will work. Okay, so there we see one of the balls bounces beautifully. The other one drops like a sack of potatoes. They have different ability to dissipate energy to absorb energy. And corneas vary in a similar way. Your eye, in fact, can be thought of as a shock absorber and balancing really the forces across the lamina cribrosa, which is where we think ganglion cell death occurs along the optic nerve. Hysteresis is going to be a measure of how good of a shock absorber your eye is, with an eye that has a high hysteresis being a great shock absorber and a low hysteresis being an eye basically with a bad shock absorber. If you need to bring it back to glaucoma, you can also think of an eye with a thick cornea having a higher hysteresis and an eye with a thinner cornea having a lower hysteresis, but it's not always that those two parameters correlate with each other. One thought is that if an eye can't absorb shocks well, if it can't absorb pressure-related stress well, it may transmit that to the optic nerve and cause damage. Ocular response analyzer is an air jet technology. This was sort of my nod to COVID. We think that non-contact ways of measuring the intraocular pressure are generally safe in terms of spreading adenovirus. Here is a quick video of the pulse. What you're seeing is an air puff is going to come and cause a wave in the cornea, and then the blink will come a second later. You're measuring the way the cornea deforms and then bends back out again. The difference between the pressure at which the cornea dents in and regains its shape tells you how much of that energy was absorbed, and that difference in those two pressures, inward applanation versus outward applanation, is how you define corneal hysteresis. It's measured with two infrared sensors. This all sort of began, hypothetically, you can imagine a lot of different reasons why corneal hysteresis, I'm going to kind of move through this, what corneal hysteresis might reflect on glaucoma, but it was Nathan Congdon with Harry Quigley, who did a fascinating study probably 20 years ago, 14 years ago, where they just looked at 230 glaucoma patients and basically found that eyes with a low hysteresis were more likely to have progressed in a retrospective analysis of their charts. And they did a linear regression analysis, and they found age was a risk factor for progression. They found people who had been treated were more likely to have had glaucoma progression, which makes sense. You treat people as they're worsening. And they found that a low corneal hysteresis was the other risk factor. And this started this field, and it led me down a rabbit hole that I've been falling into now for at least 10 years. That data has been replicated a few times. Gustavo de Moraes, working with Jeff Liebman in New York City, did a number of wonderful studies looking at risk factors for progression in treated patients. They found all sorts of neat things. They found that the peak IOP in the chart was a risk factor for progression. They found age, of course, it's the most consistently discovered risk factor for progression. But they found hysteresis again. So eyes with a lower hysteresis were more likely to progress. And one of the things they found in this study is that when you started considering hysteresis and thickness, hysteresis was always sort of winning in the regression analysis, meaning that a lot of what we think we're measuring when we measure corneal thickness is probably better measured with corneal hysteresis. And that, it's almost too profound to really take that into clinical practice, because what I've told you at the beginning of this is I can't see a glaucoma patient without knowing their corneal thickness. And what I'm telling you is that in all the studies where they've compared thickness and hysteresis, hysteresis is better. And it tells us we should be looking at hysteresis and not corneal thickness. So that to me is an earth-shattering fact. Maybe we can get Paul and Mike to weigh in on that at some point. Finally, finishing up here on the data part, 2 prospective studies, both part of the DIG study out of San Diego. This is Medeiros and Weinreb's work, observational study, really good testing protocols, visual field OCT every 4 months. They followed some glaucoma suspects, some people with glaucoma, and they looked at a number of risk factors to see how they did. Now, because it's a prospective study, you can say, you can call things real risk factors. And here's the chart that came from this study. The blue lines are visual field slopes over a 4 to 5 year period. And they divided the patients in the study into those with a low hysteresis below 10 and those with a high hysteresis above 10. And as you can see with the group with the lower hysteresis, some were stable, but there were some rapid progressors in that group. And on average, the visual fields were getting worse. The average visual field of the patients with a high hysteresis was totally flat. There were no rapid progressors in that group. And in fact, most of the field, almost all of them, are stable. The most sort of aggressive interpretation you could have from this is that having a high hysteresis is glaucoma's get out of jail free card. But you could also see how having a high hysteresis seems to be an incredibly favorable prognosis for glaucoma. So this study was then, you can look at the interaction between pressure and hysteresis. And basically what you see is that having both a high pressure and a low hysteresis is horrible. And that having a high hysteresis tends to mitigate the effects of having a high pressure. But you can start to look at your patients as where they are on this sort of risk topographical map and decide how much you need to be worrying about patients. This study was then replicated in glaucoma suspects, simply showing that eyes that had a higher hysteresis were less likely to convert to glaucoma, and eyes with a low hysteresis were more likely to convert, again, suggesting that a low hysteresis might make you a glaucoma suspect on its own, but certainly that if you have a glaucoma suspect with a low hysteresis, that they are at higher risk. Then just like on the fundamental level, hysteresis is measured with a machine called the ocular response analyzer. It also measures the eye pressure and it measures hysteresis. It can adjust the eye pressure for the hysteresis value in something called corneal compensated IOP. It's like a corrected Goldman measurement, just like we can correct Goldman for corneal thickness, we can correct it for hysteresis. So, on a basic level, in practice, I check this test on most of my glaucoma patients at baseline, and I get some numbers. I get their Goldman correlated pressure, which is supposed to be very similar to Goldman applanation tonometry. I get the hysteresis value, and those are the two numbers I focus on. I think we're about to get into cases here. Paul and Mike, I just wanted to say before I kind of show you, the cases, anything you want to add about the literature or, what you think, we've learned from the research on hysteresis that's important to before we begin looking at patients?
Yeah, for me, it's made a huge difference in our practice. I use that probably more than any other diagnostic test, more than pachymetry. And you look at a data set that was also published looking at the lamina cribosa and putting a LASIK ring on the cornea, bringing the pressure up to around, I think, 60 or 70, I believe, in the study. And they looked at the amount of displacement of the lamina and the movement using high-speed OCT. And they found that if you had higher hysteresis, you had more movement with the lamina versus if you had lower hysteresis, you did not move as much. So it really does give you a better understanding of the ability for the eye to really absorb that energy and disperse it. So for me, it's become my #1 diagnostic tool over, let's say, pachymetry. And example, even something as simple as an ocular hypertensive, if I have a patient pressure like 25 or 26, a suspect for every other reason, but their hysteresis is low, I'm treating them regardless of what their fields look like, even what their nerve looks like. That's kind of how powerful it can be for me. So I think it's definitely improved my decision processes and my decision tree really starts a lot of times with that hysteresis measurement.
Yeah, and one thing to add on that and one other point, but when Paul mentioned, when they increase the pressure inside the eye, the lamina kind of displaced a little bit more. And in my mind, how I understand that is there's less chance that the nerve fibers are going to kink when they go across the lamina cribrosa, and it keeps them from, interrupting that axonal transport. And then the second point, Nate, you touched on it, how you can't see a patient without knowing their corneal thickness and without knowing, what their corneal hysteresis is. I was in a unique situation where I had corneal hysteresis as a fellow, didn't have it when I started practice. And man, it was really hard to, put all the pieces back together. And then now I eventually have it again. And so, but not having it for that short amount of time was very interesting and really changed how I approach these glaucoma patients. I felt like I didn't have something that I used to have and I really missed it.
Yep. Yeah, good. Good thoughts. Interestingly, there's a whole other aspect of hysteresis looking at corneal biomechanical stability, keratoconus. Hysteresis does go down after LASIK. As you might suspect, the eye is less sort of biomechanically stable. But I thought I might start with something that we've seen all the time, which is, simple case, a patient comes in, the pressure could be 21, you start them on a drop, and they come back, and their pressure is still 21. It happens all the time. In fact, in some studies, it happens to 20%, and you read that 20% of patients are latanoprost non-responders. And, I always took that to mean that they're missing some receptor or somehow, the action of latanoprost doesn't work for their eye. So I'm showing you a patient here with some glaucoma, some RNFL defects, and a little field defect. Pressure is 20 before and after latanoprost. What are the causes of non-responders? I go through my list. Non-compliance, true non-responder. The compliance, sometimes you can see, if you're lucky, you'll see a side effect, like a red eye. Anjali Barade has a wonderful paper from the OATS study on IOP fluctuation and how, if you catch fluctuation wrong, you'll think your drops either aren't working or you'll think they're working better than they really are. Can work both ways. 20% of patients will have a 20% IOP fluctuation between visits. And in biomechanics as well. But, clinically, how do you approach those patients? See, they say they're taking the drop and nothing happened with their pressure.
Yeah, I mean, you did a great study. I believe it was you who just showed that when you have high hysteresis, you don't see a significant reduction of IOP, and even ocular hypertensive we don't see that reduction that we like, and thicker corneas, and they tend to have thicker higher hysteresis measurements as well. So, I think it has to do with, again, all the different variables you mentioned, making sure they're not that they are compliant, making sure that you're testing them, appropriately throughout the day if you need to. And then a lot of times I'll switch to an SLT in these kind of patients for the most part to try to see if that will help, whether it's absorption in the eye or other issues as well. But you got to follow with the nerve in the fields. But I do think that it is helpful when you have a high hysteresis to explain why they may not have that lower IOP or that reduction that you expect from the PGA.
I wanted to congratulate you for making it 15 minutes before you brought up SLT, Paul.
Trying, man. Trying.
No, I agree. I would often go for SLT. Okay, well, so this is actually the study Paul was talking about. Can you guys all? It tells me my connection's lacking, but so this is Jamie Brain's work with corneal thickness in the ocular hypertension treatment study. And, he found that people with thick corneas only got about a 23% pressure reduction from latanoprost. And thinner corneas got up to 33% pressure reduction. So that got me thinking, makes all the sense in the world. If you have a thick cornea and a high pressure and you lower it with a med, if the cornea still has, properties that provide an artifact, you didn't change that, you're still going to get a high reading. Well, with hysteresis, it's that same effect, but magnified. So my patients in my practice that had a thick or a high hysteresis got a 7% pressure reduction from a prostaglandin analog. I mean, that's pathetic. And those with a very low hysteresis would get 30% pressure reduction, which sounds great. But there's a big problem here, which is I just finished telling you that people with a low hysteresis are at worse risk of progression. And so you're patting yourself on the back for having put someone on a drop and gotten 30% pressure reduction when they're still at risk. And what do we typically do when someone doesn't respond with a high hysteresis? Well, we either put more meds on or we laser them or do something more aggressive when in fact they have a lower risk. So this is kind of one of the key insights I think you can get from looking at hysteresis. In one study, and here I go, Paul, talking about SLT. Here's my video. I finally got the camera rigged up to my SLT machine.
There you go.
In this study, we had, or this was a study, basically showed that the lower your hysteresis was, the better the pressure reduction from SLT. And you can think of it a couple different ways. One is an eye with a low hysteresis is more likely to show you how much pressure reduction it's getting because of the biomechanics. But two, an eye with a lower hysteresis is probably in more need of pressure reduction. And we'll talk about what happens with MIGS too. So here's another patient. It was a 70-year-old man. You can see some nerves that don't look great. I mean, there's sort of diffuse, mild RNFL loss. The field is mostly full, but pressures of 28 with a corneal thickness of 545 microns, full field. And I think we do a risk calculation here. So I still, if you've never seen this, Google the phrase ocular hypertension risk estimator, and you get this nice little PDF. You can enter the, all the variables you have, and you can calculate your risk of developing glaucoma. This patient had a 30% risk of getting glaucoma based on ocular hypertension. You might argue based on the OCT, they already have glaucoma, but either way. So high risk, and I think 5 years later, the patient was treated, presented with pressures of 28, corneas, again, we said a little thin, but mostly normal. But the pressure never came down. They were on a prostaglandin analog, a beta blocker, and a carbonic anhydrase inhibitor. Pressure only came down to 24. How is this patient doing? Now, we know why they're on 3 meds. They're on 3 meds because their pressure never came down. What are you thinking, Mike and Paul, that you're going to see in terms of this patient's hysteresis?
Based on the stuff that you showed already, I'm guessing that he probably has a little bit of a higher hysteresis. And I'd be curious to see, based on OCT and field, if there's any progression there. My hunch is maybe not.
Yeah, it's a good hunch. So no progression after 5 years. And you got to look at a patient who's been on three medicines for 5 years with no progression and wonder if they really need all that treatment. So old plan, with a pressure of 24 on 3 meds, sometimes you're thinking about surgery or, something aggressive. In this case, the patient was just monitored. I think you could even give some consideration to withdrawing medications. That's where I might start to look at the patient's age, likelihood of blindness based on whether they're younger or older patient. I'd probably start to withdraw some meds. Paul would perform SLT and stop 2 minutes, wouldn't you?
There you go. You know it.
It's a good.
No, I think I agree. You had to take the longevity, all the different variables of how aggressive we want to be, and so that's a really good point. If they're 45 or 50, I'm probably going to keep be much more aggressive.
I keep teasing the MIGS topic, but you can use this therapy, this concept to guide your expectations from MIGS as well. So this patient had a really high hysteresis, 13 millimeters of mercury. If you start adjusting their pressure, maybe now they're more like a 19, but their risk is low. As you saw in the Madeira study, patients with a hysteresis of 13 didn't progress. They just didn't. So there is consideration to stopping or cutting back on therapy.
And Nate, I think the key was he was 545. So one would think, okay, their CCT would be like 620 or something high. But there's a lot of these patients where the CCT may be average or even slightly thinner, but yet your hysteresis is high or vice versa. So this is where that disconnect in some cases can throw you off. But I definitely trust the hysteresis more than the CCT in these patients in terms of my risk profile.
Hey, and Nate and Paul, one of the questions that came up was, how to use it in clinical practice. And I think one thing they're wondering is, what's your cutoff from what's a high hysteresis and a low hysteresis in your mind? And I kind of use 9.5 is kind of my cutoff from high and low. Are you guys in the same ballpark?
Yeah.
Pretty much. Yeah, same. I mean, if they're like below 9 or above button 10 or above, happy if they're above 10. If they're below 9, I get more concerned.
Yep, I love to see 11 or 12. You know, in someone it's more reassuring. And it's not uncommon for advanced glaucoma patients to have a 6 or 5. You know, hysteresis does come down over time the longer you've had glaucoma. You know, you may hear there isn't a strong relationship between hysteresis and eye pressure, but it's a little complicated. Basically, if your pressure is 50, your hysteresis is going to be very low. So at the extremes, a high pressure will immediatly reduce hysteresis. In the
just a couple of questions that came up, if you don't mind, just on the chat group here, just about keratoconus. So questions came up about well, in general, like, is keratoconus associated with glaucoma? That's a general question, and then specifically, you know, these patients, you know, have lower hysteresis. I think, Michael, I think you kind of answered a little bit on the text. What are your thoughts just in general? Does keratoconus a risk factor? Do patients with keratoconus have a risk factor for glaucoma? Sorry. Get that. Oh, is maybe it's mine. Sorry, it's my phone. I'm on call today. Or is it not associated? And then what about corneal hysteresis? Because of course in people with keratoconus, their corneas are abnormal. So I don't know who wants to take that and comment on that. And we have Sahar too, by the way. Sahar is here, and Miriam is are here too. So don't, you know, if you want to tap into them.
If I may offer a comment as a cornea specialist.
Oh my God, cornea comes. Okay.
Yes. Here I come. There's actually a publication by Elizabeth Cohen. It was published, I just pulled it up. It was in Cornea in 2010. And it's called Keratoconus and Normal Tension Glaucoma, a study of the possible association with abnormal biomechanical properties as measured by corneal hysteresis. Bottom line is, we're so focused on the cornea when we're looking at the keratoconus patients that the main message is, yes, there can be some susceptibility to some of these developing glaucoma, and we should include that as part of our ongoing evaluation of keratoconus patients.
Yeah. I just my personal opinion, I know you think, Matt and Sahar and Mariam, I wouldn't mind getting your opinions too, but I've generally felt that glaucoma keratoconus, I don't really see an association myself. But again, those are different patients too. They're younger typically when they often see us.
And I would say there's a difference between the association, but also the fact that we should not lose sight that some of them could develop it. Not like a causality, but just because we're so focused, as I said, because we're so focused on the cornea, that we should still be monitoring them, because some of them may have that incidence, that higher incidence.
Well, I guess it brings up the point. I mean, people with keratoconus have a, you know, abnormal hysteresis, and how's that associated with glaucoma? I think we need to differentiate. People have abnormal corneas. There was a question about LASIK. I think the associations with hysteresis measurements and glaucoma really probably only truly apply to a normal cornea. Would you say that would be true, Nate? What do you think about that?
Yeah, so Ike, the study that I think the Elizabeth Cohen study, John Myers was author on that as well, and they found both the hysteresis was lower in normal pressure glaucoma and in keratoconus, but that it wasn't especially low in people with both. And so I think that kind of supports the concept. Also, my understanding, keratoconus, the hysteresis is lower, but it's not a great discriminating factor, and you can't use it on, you know, by itself.
Yeah, Nate, sorry to cut you off, but what I was going to add, and I think where you were going was, you know, keratoconus, we know it's a big mechanical problem too, where people are rubbing their eye like crazy, and that's one of the major reasons why they develop keratoconus. And so maybe they've got a slightly low corneal hysteresis, but the mechanical rubbing tips them over the edge. Where with glaucoma patients, there's not someone inside your eye, you know, rubbing the lamina cribrosa, and so it's more of a corneal hysteresis problem than a mechanical one.
Yeah, and then just again, some questions that come up about people with LASIK who have a decrease in hysteresis. Does it increase the risk of glaucoma?
Yeah, I would say it doesn't, but you now have some insight into the inaccuracy of your pressure measurement, and you may be able to use that. In fact, the initial corneal compensated IOP measurement, which remains stable with LASIK. So your corneal compensated, which is a Goldman pressure corrected for hysteresis, doesn't change before and after LASIK. And so it may be a helpful tool for getting a more accurate pressure. It doesn't tell you anything about their risk, but it can still be useful clinically.
Sahar, I think you're going to say something.
I was. So the way I look at hysteresis is not just the cornea, but it makes me think about the overall characteristic of the collagen in that person. So their cornea, their sclera, the lamina cribrosa, how strong it is, how pliable it is, how cross-linked it is. And so that is what actually tells me. So when I think about hysteresis, I really think, okay, what's going on at the lamina cribrosa? Is there support there on the scaffold or not? Or does it lead to more apoptosis? So I look at it at a little bit more of a global aspect as far as the eye is concerned, and not so much focus on just the cornea. I think about the overall eye and the overall collagen. And I'll oftentimes ask patients with, unusual IOP or unusual glaucoma if they have any kind of collagen disorders or, rheumatoid arthritis or something that is, kind of affecting their connective tissue. And they oftentimes do have some kind of relationship.
Yeah, I think you're absolutely right. And it's a closed system, right? So even though we're measuring the cornea, it's representing what's happening in the entire eye as a closed system. So yeah, I agree with you. We gotta look at it more globally than just looking at the cornea properties itself. And you look at studies too to show, if you look at unilateral glaucoma or patients who have POAG in both eyes, but one eye is worse, I forgot the study itself. I think it was like 90+% of patients who had disease in worse in one eye had lower hysteresis in that eye. So, there's also those patients who are even kind of getting worse on you. You don't know why they are. A lot of times you get the hysteresis, you say, wow, they're much lower in that one eye, and that'll tell you to be more aggressive. So there's a lot of value outside of just looking at the cornea.
Yeah, I think the message here is that I think it's a surrogate for looking at ocular hysteresis or ocular dampening. And so if you abnormally change the cornea, if the cornea independently changes from the rest of the eye, then you have to be careful just using that as a surrogate. That's what we're looking at. We're looking at hysteresis as a surrogate from the cornea to give us an idea what's happening in the rest of the eye, particularly the lamina and posterior sclera. So I think it's important to differentiate. Someone with LASIK whose hysteresis changed artificially, I don't think we can make the same relationship to saying that risk factor is the same as someone who hasn't had LASIK and has a low hysteresis, for example. Okay, we'll come back to some more questions. It's questions about cross-linking hysteresis, everything else. So Nate, you've opened up a lot of questions, and Michael, thanks for answering some of these questions on the chat group. It's great to have everyone chatting and talking while not paying attention to Nate. I'm kidding. Keep on the chat. Keep up the chat.
In terms of artifact,
I think we're losing you, Nate. I think your microphone's steadily dropping down into your trousers.
Yeah, are you losing me? I'm trying moving around my house until I.
Yeah, what are you doing? You're running away from somebody or something, or what? Are you social distancing?
I'm trying to find a good signal.
Trying to look for good Wi-Fi in New York.
So
we can't hear you though, Nate.
Can you hear me?
Barely.
Really? Yeah.
Better.
Okay.
At the beginning of the talk, you were great though. Wherever you were before was really good, really clear.
I'm back here. Okay. Yeah. So
now,
I was saying.
Maybe try the washroom. Maybe.
I'm close. Diabetes seems to be associated with a higher hysteresis. It's unclear why, and you can't hear me.
Not too well.
Can I call in? Does that work?
Just shout really loud.
Just shout really loud, man.
Off your microphone. Do you have your finger over something?
You were good earlier, Nate. That's what's weird. You were good earlier.
Did I tell my daughter to stop watching Netflix?
No.
How are we right now?
Good.
I probably just shout a bit maybe then.
Okay. So what I wanted to just say, diabetics have a higher hysteresis, and hysteresis drops with age, it drops with duration of disease. Let's go to the next case. So here's a patient who didn't do well. 59-year-old, pressures of 21, average cornea, OCT damage, field looks okay. And again, you can calculate some risk, sort of average risk. I mean, this patient already has glaucoma based on the nerve. And it becomes a question of whether you would treat. I think, again, if you look at this nerve, it's not, there's a lot of asymmetry between the right and the left eye on the OCT. That to me can be reason to treat. The field isn't perfect. By the way, this is a case, to Paul's point, where if you had a big hysteresis difference between two eyes that have a different OCT, that can push me into treating a patient just in and of itself. But this was an era when we didn't have hysteresis. So I think that we'll see what we decided to do with the 22% risk. We watch the patient without therapy and see in 6 months. And here is prior to treatment, or this is what happens in follow-up. You can see some change in the OCT. I'll draw that out for you. So the top OCT is baseline 2016, and then a year later, you've lost some RNFL, both quality scans, similar signal strength, and looks like progression. After the fact, you're going to check hysteresis now because we didn't have it at baseline. And there's a low hysteresis. Again, that 6.8 is a pretty remarkable number. So this is just a simple case, but it shows you, often explains patients why they progressed once you get the test. And one of the things I will say is that if you start using hysteresis, you'll get plenty of bad news about patients. And, Mike and Paul, I might ask you, do you always act on it? Some days I feel like I get a lot of bad information by measuring hysteresis. What would you do in this case? So this is someone you didn't treat, and you see they've progressed and they've got a low hysteresis.
I'd be aggressive in this patient. I mean, not just the hysteresis, but that field loss in a 59-year-old young lady. That's young, and you have plenty of time that you have to deal with this patient. So this is someone I would definitely be much more aggressive with, getting the pressure down to the middle to lower teens, just because of that progression so significantly in just a year or two. And they've probably been progressing all along. We just couldn't detect it. But this is a great example of where, when I get, even at the top in 2016, if I had a 6.8, that would tell me to go from upper teens to as a target pressure down to the middle teens or lower, because of the fact that the hysteresis is so low. So it also affects how aggressive I am. Not just if I'm going to treat someone, but I'm going to be much more aggressive in someone who's young and has that low of a CH measurement.
Yep. Nate, I think we lost you.
All right, Michael, we gotta start talking, man.
He lost his voice.
Oh, you guys do this case. I'll surprise you.
Yeah, there you go. Wait, when you lean in close, we get you.
Oh, does it?
Yeah.
No.
Now we can hear you.
Yeah, come really close, Nate.
We want to see your beard.
I see what's happening.
No, seriously, man. A lot of people are writing your volume is really low, but I know you're doing your best. But
okay. Yeah, no, I'll speak loud. This helps.
Something's weird. It's like something covering your microphone or something. I don't know what to say. It's weird. We're getting a tour of Nate's house.
There you are. That is bizarre. Where is the microphone on a Mac anyway?
Right where it says MacBook Air.
Yeah, it's MacBook Air.
That's where the mic is, I think.
Oh, really? Interesting. Okay, well, can you hear me now?
Yeah, we got you now.
I'm afraid I don't want to say no. So
yeah. Okay. So here's another 53-year-old patient, high pressure, slightly thin cornea. Again, some suspicious nerves. Again, this is, I think, a progressor. Patient comes down with prostaglandin therapy to about 18, and you monitor for a while. So, generally, Mike, you get someone baseline pressure 26 down to 18 with mostly full field. Are you happy with that?
Yeah. Yep. That's kind of where I'm shooting for.
Okay. So, and this patient's monitored with those pressures. Again, just sort of an average risk. And again, you're going to see an OCT here with progression. I think it's about a 7 or 8 micron loss in retinal nerve fiber layer in the right eye. That's about the just noticeable difference in terms of OCT. That's about where you can start to call progression on OCT versus fluctuation. And again, looking at the amount of difference, we see 6 micron change. Again, something believable to me. But someone who's already had good pressure reduction. And so 26 down to 18, you got your 30% pressure reduction. Why are they still progressing? And I kind of go back and forth on this. And Ike, maybe I'll pick on you here if you can hear me. Which is, if you see OCT in someone that you just got a 30% pressure reduction in, do you think maybe that's from the pressure before you started your treatment? Do you wait it out a little bit, or would you still be more aggressive?
Is that for me? Is that for Ike or Mike?
Ike.
Oh, yes. Well, I mean, there's so many reasons why what we think is an office pressure of 18 by Goldman tonometry with invert Fick, presuppositions and problems that we're off. And I obviously believe that IOP is a major risk factor. And so either compliance, fluctuation, or we truly need to be lower because of the histo and the corneal and the ocular biomechanics. So for me, I mean, I'm pretty aggressive. I mean, 55-year-old, I would be, more than happy to get lower, and I would need just more evidence to give me that. And I think that's I think where for me, it's hard sometimes to tell a patient, well, I need to get you lower. Having some evidence like this, whether it's hysteresis or otherwise, helps us. Now, the progression, of course, tells you enough to say, assuming this progression, that something needs to be done more than you've already done. So I think you have a couple of things already to tell us that it's important. So for me, yeah, I mean, I look at this. I look at this though. Simply adding drops may not be enough because this patient may again be not compliant. This patient may be fluctuating. So I would look to again interventional approaches. I mean, whether they're laser trabeculoplasty or drug delivery or even MIGS in some of these patients, because I think that the problem is multifactorial.
Yeah. And if you had hysteresis, at the beginning, again, maybe you could predict that.
So yeah, so this was someone who, had a low hysteresis. And again, it just points to me to the point that this paradox with hysteresis, where a low hysteresis, you may see nice pressure reduction, but they still may need more because of that high risk. And I'll because I see we're about getting to the end of our segment here. I'll share my MIGS experience. Well, first of all, I got some cool pictures here. So this is we did one study showing that you were more likely to see change on optic nerve photos if you had a low hysteresis. And that really surprised me, that an air puff against the cornea could end up showing up in the optic nerve. And we just recently published that disc hemorrhages are more common in eyes with a lower hysteresis. And again, it's just amazing that somehow blood is more likely to appear on the optic nerve when your hysteresis is lower. The final comment I had about MIGS, I know I can't give a talk to Ike's group unless I do something with MIGS.
This is Nathan Radcliffe demonstrating an omnicanaloplasty.
We're going to mute that. Okay. In my MIGS patients, when I looked at hysteresis, I found something kind of interesting. If you had a high hysteresis and we did MIGS, those patients were very successful at getting off drops. They didn't have too much pressure reduction, but they did a great job of getting off their drops. Now, if you had an average hysteresis, let's say 9, and you had MIGS, you did well in terms of both reducing your pressure. These are average for glaucoma. You did well in terms of both reducing your pressure and getting off drops. Those people did the best. So hysteresis at 9, MIGS, you did well, got some pressure reduction, got some med reduction. My low hysteresis, let's say my 6s, when they got MIGS, a lot of them failed. A lot of them ended up with a tube shunt, 4 months later. And maybe had I known the hysteresis, I might have said that I need to be more aggressive. I might have taken a more careful look at whether they were progressing rapidly. It seemed as if MIGS wasn't enough for some of those patients. So again, it just kind of gets to ways in which we can use this to kind of help us make some decision making. And I'll sort of leave that up to discussion, but that's also sort of the end of the slides and the cases.
Well, thank you, Nate. We've had a good discussion during your case. We probably have to move quickly forward, but and I'm hoping the rest of the panelists, you guys can stay on if you're able to. We have some anterior segment stuff, and we also get back to glaucoma after as well. And I think that, you know, we've now been using hysteresis for some time now, and I think that although I know it's not accessible around the world and everyone doesn't have the technology, if I think I look at it this way, if I felt that corneal thickness was important, and I'm asking that kind of rhetorically, I look at this as an ability to look at corneal biomechanics as thickness on steroids, basically, where we have much more information. So thanks for sharing it. And I'm pleased at least the evidence, like the DIG study. I mean, the DIG study is a pretty important study, prospectively done, and pretty conclusively showed the results looking at hysteresis. And for me, that was probably the biggest, I think, the final point for me to kind of say, yeah, this is kind of, I think, important to look at the risk of progression. Just as if I look at disc hemorrhages, for example, in the same kind of study, or if I looked at other risk factors that we know of. So thanks for sharing that. Jeb, we're going to move along, I think, to our next speaker. I think Dr. Rocha Guillermo.
Good. I'll share my screen right there. And let's see, can you see it and hear me well?
Fantastic.
Excellent. Well, thank you, Ike, and thank you, Jeb, for organizing these, as I've said before. And these are excellent ways of structuring our weeks and maintaining collaboration, as well as keeping our brains busy during this time of pandemic. So thank you so much for asking me to participate. I also like to acknowledge my two co-panelists here, Amandeep Ray, as well as Alex Lichtinger from Mexico City, and Amandeep from Toronto. And the topic of my talk today is when to break the posterior capsule on purpose. So the other thing, just like they say in the newscasts, thank you, all of you, all the 350 something participants, for, like they say, very corny, allowing us to come into your living rooms. And so thank you all, and we'll start with this. So
Guillermo, I mean, Nate tells me this happens. This is all the time. Whenever he breaks capsules on purpose, so he's an expert with that.
Exactly. All right. So there are two big no-nos in cataract surgery. There are two big no-nos, and the first no-no when we're training is never touch the corneal endothelium, and the second big no-no is never break the posterior capsule. So the goal of this talk is to actually break a little bit from these two no-nos, because there are instances where we want to do something a little bit more different, and there are times where we need to adapt. And so the first big no-no is eliminated with the advent of endothelial keratoplasty. So I remember the first time I ever did this endothelial scoring to remove Decimus membrane was kind of like I felt that I was behaving badly, because all these years I was supposed to never touch the endothelium. But of course, that has really transformed corneal surgery. The second big no-no is when we break the bag. And so there are certain instances when we would like to break the bag, such as when patients have poor cooperation, poor mobility. And remember, I'm saying to break the bag in a controlled fashion, poor mobility or poor positioning, simply to reduce the risk of posterior capsular opacity and need for YAG, and geographic or other practical reasons. And here I'll tap on perhaps Amandeep. Do you want to add some comments here, Amandeep, for why would there be any reasons to, in a controlled fashion, open the posterior capsule?
Yeah, absolutely. I mean, I think one of the big reasons would be we know that the incidence of PCO is not low in the cataract population. And for a variety of reasons, people may not be able to come back for a YAG capsulotomy. I think very often when we're doing surgery, we say, oh yeah, we'll just YAG that later. But sometimes you can't YAG that later. The patient can't come back, or more commonly, the patient can't sit at the YAG laser. And that may be due to developmental delay or neck issues or whatever. And I think that's something you need to anticipate, especially, and of course, we've always seen in the pediatric population.
How about you, Alex? Mexico has a bit of a different system, and you work in a different system where you see some, you have a teaching hospital, but also you have a private practice. Would there be any financial considerations to considering maybe opening the posterior bag?
Of course, I think for me there are basically three indications for trying to open the bag in a controlled manner. One of them would be pediatric patients, where we know that rate of capsular opacification is very high, and that it's going to be impossible to see these little babies for a YAG capsulotomy. Patients that we're not going to be able to follow up because they come from far away and they don't have access for a YAG cap if needed. And special cases where, you know, they have neck problems or they have Parkinson's, in which doing the YAG capsulotomy would be very difficult. So I think it's very specific indications where I would think about doing this in a patient.
Excellent, thank you. So I'll move on. So one of the pieces of anatomy that we learned long ago is this. You have the lens right here, then you have Wigger's ligament right here on the periphery of the posterior aspect of the capsular bag. But then this is an important space, the Berger's space, or the space of Berger. And so this is where we're actually going to focus a lot of the maneuvers that I'll be describing soon. And so the goal is basically, once you've completed your anterior capsulotomy and performed the cataract surgery, then we're going to proceed with opening the posterior capsular bag with a posterior capsulorhexis. And what I'll try to do in the next few minutes is essentially give you a step-by-step approach on how to do that, and hopefully you'll feel comfortable. Maybe even be the first case you do after the pandemic and see if you are ready to perform this. So the steps include the following. Inject balanced salt solution, BSS, through the zonules to separate Berger's space a bit. Second, the viscoelastic to the anterior capsule to flatten both leaflets. So you don't want to create an opening in the bag, but rather flatten it. Then you take the cystitome to puncture the posterior capsule and inject a bit of viscoelastic to push the anterior hyaloid backwards. The next step is to take your microforceps and perform the capsulorhexis. Next, use the viscoelastic to separate the anterior from the posterior remaining leaflets. Then you insert the lens into the capsular bag, and you can do it in stages, and I'll demonstrate that. Put the haptics in the bag, and then buttonhole the optic. Don't push too hard because everything will fall backwards. And then you can breathe. Okay, so we'll review a couple of videos with this. So this is the first video, and what you see here is there's no labels or anything, but there's viscoelastic, there's a BSS through the zonules. The next step will be viscoelastic, which I have placed already. And then we're gonna puncture the posterior capsule. And it's a bit of a different situation. Right now we're injecting viscoelastic right there to separate the anterior hyaloid. And then I'd like you to look at the way the capsule behaves. And I'd like you to look at how the forceps is pulling and the forces that are taking. You see, I'm pulling a lot more centrally, as opposed to when we do an anterior capsulorhexis. And I advise to make sure you're not grasping vitreous. That's the whole point of putting viscoelastic. Feel free to change and go through different paracentesis. And look at the maneuver here that it's not really following it, but it's more of a central pull because these posterior capsules can be very, very elastic. They behave a little bit differently. So you'll see there. Now it's tempting to continue there, but stop right there, regrasp, and then finish that off so that it pulls in a central way. And you see we have the anterior capsular opening, and then we have the posterior capsular opening, which is smaller. That's a very important thing. It's smaller than the anterior one. Now I'm separating the leaflets here. So separating, and then you can do it by inserting the 3-piece lens. It can also be done with a 1-piece lens. I prefer to do it more frequently with a 3-piece lens, injecting into that space that we just created, and then try not to rotate too much. Just ever so slightly, just to get the optic there, and then we'll push the trailing haptic right in there. Okay, and that's basically it. And then we will buttonhole it, and I'll explain that in a second. So reviewing the steps: balance salt through the zonules, viscoelastic anterior to the capsule to flatten both leaflets, cystitome to puncture the posterior capsule, viscoelastic to provide a small fill and separate or push back the anterior hyaloid, microforceps to complete the capsulorhexis, viscoelastic to separate the anterior and posterior leaflets, and then insert the lens, do it in stages, haptics in the bag, buttonhole the optic through the posterior capsule. Once again, breathe. Okay, so we'll review it, and now I'll label each of the steps. So step by step, as I mentioned, there we go. Let's try this again. All right.
Guillermo, just as you're doing that, I think there's some good comments on the chat group about, and I think Alan Carlson's back here again, and I think he makes a good point about the key with these techniques is to ensure that the anterior hyaloid remains intact. And
exactly,
one can compromise a capsule if the anterior hyaloid is kept intact, and the eye doesn't necessarily know any better, as Alan wrote.
Exactly.
I'm really curious about the BSS because I typically don't inject BSS or try to put BSS around the zonules.
Yeah.
I find I haven't had to do that. If I simply make an opening in the capsule, put OVD in,
yeah,
that increases burger space. And I guess I just would worry about BSS and that could you put too much in? Could you end up getting into the vitreous and end up hydrating? I think it's probably unlikely, but I haven't heard that approach actually.
No, and I think the first couple of times that I reviewed the technique many years ago when I started reading it was a lot of the technique came from Austria, Stifler and Menepes, and so I started doing it that way. But you're right, I don't think it's absolutely necessary, and I do share that concern. I have typically done it that way, but I don't think it's absolutely necessary. I would agree with you. So I'll show here the steps now, and I'm not sure why this is not going. Let me just, because this one is a bit of a better video. So I'll just let it run and see, hopefully. You may have to, there we go. No. Maybe you want to run it from your computer, Jeb?
So while it loads, there's another couple of options or techniques that people do to kind of separate the hyaloid from the posterior capsule. One of them is just polishing the posterior capsule once you're taking out the cortex, and the other one is just flushing with BSS on the posterior capsule from inside the capsule, and that kind of those waves kind of move the hyaloid from the posterior capsule. Let's see the video run.
Hey, Guillermo, there's a question here for you.
Yeah.
Do you adjust your IOL calculations if you're optic capturing through the posterior capsule?
No, I don't. Because essentially you're buttonholing it, but the effective lens position is going to be the same.
And then one more here for you is, do you make the decision for posteriorhexis preoperatively or intraoperatively?
I usually, and the only time I would make it intraoperatively is if I ding the posterior capsule, and that's not on purpose, okay? And then I might be able to convert it. But otherwise, the decision is made right off the bat. So I'm not sure why I'm not able to run this video.
So let me give it a try.
Okay, give it a try, and then I'll go back to the remaining slides. Thank you.
And then some more questions about doing the rhexis. I don't know if you answered this question, was about doing it before or after an IOL is inserted. In some cases, I think Matt mentioned that he does it after the IOL's in. I've done both.
Yes.
And I guess the advantage there, if it does end up being incomplete, the IOL's in there, and the risk of having it tear wider.
I've done both as well. Yeah. So there's the video.
Okay, Jeb, why don't you try to play it here?
Is this the right one now, Guillermo?
Yes, that's the right one.
Okay, so let me just rewind a little bit so you can go back in there. Here we go.
Sure, there we go. It's looking a little bit sketchy, but anyway, you get the idea. OVD to flatten the leaflets. Yeah, I agree. I've done it both. I prefer to, I think I have a bit more space, obviously, without it. Then the puncture.
It's a bit sketchy. It's a bit sketchy because Jeb has lots of other videos on his laptop, and it's a lot of memory.
Okay.
Jeb, if you do go to the video settings, though, if you go to hit the More button, and then you can select Optimize for video playback. See that?
Okay, optimize full screen video clip screen sharing. Is that any better?
Okay, so here's the, yeah, it's better. So look at the elasticity of the capsule. And so be very careful. Obviously, the mechanics, the motion is not the same as when you're doing the anterior capsulorhexis. And so take your time, make sure you're not grasping vitreous, make sure you have the leaflet or the tag in there. But you see, I'm almost done there, but I'm going to re-grasp and see the movement. The movement is right towards the center. And then that's the completion. And then what you'll see here is the inflation of the, or the separation of the anterior versus posterior leaflets. So we're creating that space right there. And then my preference, as I mentioned, is a 3-piece lens. This particular lens is kind of like a planar insertion, so it doesn't twist or turn, so I like it. And it's going just ever so slightly scratching the posterior aspect of the anterior capsule. And so that haptic is in, then the optic is in, then we push gently the optic, and my preference is to grab the same microforceps and then just grab the trailing haptic and then just gently put it right there. Now, look at the pushing. This is irrigation aspiration, and you can do the buttonholing either after or before. Nowadays, I do it more often before I do the IA, and look at the pushing from one side right there, and then the other side. So 90 degrees apart from the insertion of the haptics. So that's essentially the video. And yes, Sahar, I always do by manual. So I'll share the remaining slides from my screen, which is now.
If I could just make a comment, something that I found helpful is when starting the Rexis, I just use the dispersive viscoelastic cannula with either a 30 gauge or a 27 gauge needle, and kind of, you know, kill two birds with one stone, open it up and also start injecting my OVD right away with, again, the hope of not breaking that anterior hyaloid.
That's a great idea, Matt. Yeah, that's a great idea. Excellent. So a couple of words on the buttonhole. Ensure the posterior rhexis is smaller than the anterior rhexis. Buttonhole with the OVD prior to irrigation aspiration. I think it's easier. And then press 90 degrees perpendicular to where the haptics are inserted. Now you can see here the effect of the posterior capsule right here in blue, and the effect of the anterior capsule. So that's basically the effect of the buttonhole, and the kind of the folds that you want to see. It kind of creates an oval shape. So I'll ask Alex and Amandeep, what potential problems do you think there could be with this technique, with this approach? I mean, in terms of the usual post-op follow-up with conventional surgery, and in terms of what you could potentially see with this technique.
Well, I'll take that one first. I think one of the potential problems is that you would have an IOP spike from the viscoelastic, although there's studies that have shown that it doesn't happen as long as you have the optic well buttonholed, so that keeps the viscoelastic in regular space behind. As long as it's not in the anterior chamber, you're not going to have that. I see more potential for intraoperative complications if you don't do this carefully, right? That, you know, you could break the capsule, you could potentially break the hyaloid face and have vitreous come forward. But I think when it's done well, it's a very good technique for those special cases.
Any comments from you, Amandeep?
Yeah, I think, I mean, as Alejandro alluded to, I think intraoperatively is a big worry. And then maybe some of the post-operative manifestations of intraoperative complications. So if you've disturbed the vitreous face, you are at risk for retinal tears, detachments, CME, even if vitreous hasn't come forward, but just if you do manage to tickle the anterior hyaloid face, I think that can increase those risks. Now there is a question for you actually, Guillermo, here.
Yeah.
What about leaving the optic in the bag and not buttonholing it?
Well, I'll show you a couple of things here. So I'll address that in a couple of slides, but that's a good point. So complications all are rare, and many of the studies come from Vienna. And so there can be vitreous prolapse into the AC during surgery, most likely if you push too hard and you disturb that vitreous face. Vitreous entrapment postoperatively as well. increase IOP from the viscoelastic, but as Alejandro mentioned, if you put the buttonhole properly, then that should not necessarily be an issue. There's other concerns with retinal detachment, CME, that really are not evident in many of the publications. And then finally, there is still a chance that you may develop growth of lens epithelial cells using the IOL as a scaffold. And so there's still that chance, but it is very, very rare. So in terms of pressure, as you were asking, Amandeep, so this is with posterior buttonholing. And when conventional cataract surgery is compared to this technique with primary posterior rhexis with buttonholing, the evolution of post-op evolution of the IOP is essentially the same. In this, so there's no issues with IOP, but you must have that posterior optic buttonholing, because if you don't, here's the difference. Here's the round opening and the lens is in the bag. And here in this other situation, you have the oval shape that you actually need to see at the end of your case. And in these cases, there is a chance of IOP spikes if you don't put the buttonhole. So I think the main thing would be that there is migration of the viscoelastic into the anterior chamber, and that could cause a pressure spike, which is not seen if you properly buttonhole. I mean, there are times in answer to your question, Amandeep, I mean, there are times where you are either the posterior rhexis is not perfect, it's maybe bigger, you can't really buttonhole. And so I don't think there's a big problem in just leaving the lens like it is in this image. But of course, there might be more of a chance of having posterior capsular opacity and perhaps in the early postoperative period, also increased intraocular pressure. Now, this is an example showing the effect on YAG laser rates at 3 years with the conventional versus using the primary posterior capsulorhexis, and you see the differences there of 60% versus 3.5% in this particular study. So the learning point: don't be afraid of breaking the bag, especially on purpose. Consider patients who will be unable to have a YAG capsulotomy. Learn the steps and performed all of these in a controlled maneuver. Risk of IOP spikes or CME is extremely low, and especially risk of IOP spikes, especially if you do the proper buttonholing. I don't know if you have any other questions or comments, actually, Amandeep or Alex.
I actually have a question for you, if you don't mind.
Sure.
Do you change anything if it's a post-vitrectomy eye or an eye that's had other previous surgery at all? When you know the vitreous is gone, do you change the way, maybe not do the BSS or add more OPD?
I can't recall any patients where I've done that, but I don't think I would do much more of a different approach. Perhaps keeping the eye more pressurized, just to make sure that that all the forces and everything while I'm doing the opening, while I'm making the opening, stay on par. But no, I can't recall a particular case there, Sahar.
So Guillermo, there's an interesting question in the chat as well.
Jeb, you're on mute.
You're on mute.
Oh, sorry. Can you guys hear me now?
Yep.
Yes.
Yeah, so we had an interesting question in the chat. In terms of your IOL power, do you take that into account when you're doing posterior optic buttonhole, given that it's going to be a bit more posterior?
Well, in theory, if you do it properly, and I think Amandeep had that same comment, if you buttonhole it, then it just sort of moves back up, and I don't do any adjustment of the power. I'm assuming the ELP, the effective lens position, would be basically the same.
I'm surprised no one's brought this up yet, but Guillermo, what do you think about a femto posterior capsulotomy? Yes,
I have seen that reported by Burkhard Dick with the femtosecond laser. I mean, I have the femto in my operating room. I have the Victus. I use it very frequently, and I've never done a posterior capsulotomy. I think the issue is now you're talking about patients where you want to do this because they're poor mobility, poor cooperation for a YAG laser, and I'm going to be transferring them back and forth to do this. I haven't really found the need. I know it is possible to do it, but I haven't found the need to do it in my practice.
Okay, there's a great question with all these glaucoma. We got a bunch of glaucoma guys on here, and there's a question about the injection of BSS maybe bringing on attack of malignant glaucoma.
Okay, because of the
I think you'd probably, I mean, I guess what they're talking about is like, you know, when sometimes you get, it would be like a fluid misdirection syndrome. You know, like sometimes you see with phaco in weak zonules, you probably have to do a lot to get that. But like I said earlier, I do wonder whether it's needed. I've done like a lot of posteriorhexis, and I have to say, I have never done that technique of injecting in the zonule. So I don't know if you need it. I think you answer that question too, Guillermo.
Yeah. I mean, if I do it, it's like, it's just a little bit of amount. I guess that's how I learned it, but this is the point of having these discussions. I don't think it's needed either. I agree with that.
I do like the idea of going in like with as Matt said, with a bevel down, like a 27 gauge needle with the dispersive OVD on it. Once you go through the posterior capsule, you inject right away. You often get a bit of bubbles and things like that, but you certainly get separation. Well, thanks, Guillermo. We're gonna move on just to keep on to stay on time. So thanks for sharing that. And if the speakers and panelists are able to stay on, if they can, some of them have to leave. We can take some questions after as well. You know, after the next presentation. So Toby is going back to glaucoma here and is going to share a difficult case. I think you have some polling questions too, Toby, right?
Yeah. All right, so yeah, thanks Ike and Jeb for having us, and yeah, this is a great opportunity to stay connected during this pandemic, and just want to say thanks to Matt Schlenker and Josh Teichman to be my panelists. So can you guys see my screen all right?
Yeah, looks great, that's Toby.
Okay, great. So these are my financial disclosures. So now that, you know, with a lot more time at home, I started taking a lot of random pictures. I apologize if this picture offend anyone. But just want to, you know, start a poll. I mean, obviously, you know, the problem is we have a breaking point here, and we don't want to leave it alone until, you know, it becomes a bigger problem where you get toe exposure. But just want to see, you know, kind of an icebreaker, what everyone would do in this situation. Is the poll working? I know I sensed this pretty late last night, but
I think is the poll on there?
I saw it flash in front of my eyes, but let me go.
Yeah, let me just try one more time because the polls are a little bit fidgety here.
Oh, cool. All right. Yeah, I can see it.
People want to see my socks. They know how bad my socks are. Yeah, it's true.
Yeah, I think they're safe with the Crocs. Like, so yeah, I think you know, one option will be just to toss the socks away, but you know, with a lot more time on our hands, we can practice suturing on the socks. Or I've actually seen a video where someone converted socks into face masks. So, interesting. All right, so it seems like 1/3 of people would throw them away, and 1/3 would actually practice suturing on the socks. Awesome. So yeah, just you know, back to a little bit more clinical relevance here. I think we all know that in tube shunt surgery, we use some kind of material organically to protect the tube shunt to prevent exposure. So here we have an 81-year-old female that I just had recently advanced pseudoexfoliative glaucoma patient on almost all drug classes to control the pressure, and you can still see it's quite high. So we opted to do an armate glaucoma valve with donor scleral patch graft. And on day 3, pressure is doing great, off all glaucoma meds, and the pressure is 8. But I'm going to ask my panelists to comment on this. So you can see, you know, donor sclera here. Maybe I'll ask Matt what you think of this.
Yeah, so, you know, it's hard to see from the picture, but it's suggestive of an area, an avascular area over the donor sclera. Or you had difficulty with the closure and you have a buttonhole over that area. Mm-hmm. You can see this is reasonably early. We can see your, you know, your vicral, radial, and limbal sutures.
Yeah, so the closure was actually quite okay. We got pretty good coverage of the conjunctiva over, but when we put fluorescein in, you can see that there's that little crater of uptake. So this is pretty early on. This is day 3. And sometimes it's actually closer to the limbus when this happens. It's almost like a dehiscence of the conjunctiva. But maybe I'll poll everyone here to see, you know, what your approach would be.
So I think, Toby, I think it's important to differentiate. And sometimes we all get confused between like an erosion or a melt versus a retraction, right?
Yeah.
I think those are, I know they can perhaps look on a picture, they can look similar, but I think that's a really important differentiating point, and the different risk factors for that. Maybe we'll talk about that, but.
Yeah, that's gonna come up. That's gonna come up. So this one, you can see there's no tube shunt exposure. It's just an area of fluorescein uptake over the donor sclera. Great. Okay, so majority of people actually would go for surgical repair. So I'm gonna try to discuss, medical options that we can use to deal with this. And as I pointed out, this is different from what we traditionally call as tube erosion. So a lot of these cases, if we talk about tube erosion, you may see it later on in the post-op period. You can see the donor sclera or the patch graft kind of thinning out over time, with conjunctiva still being intact but covering the tube, and eventually the tube exposed. But in this case, the donor sclera is still really intact, and you can see the defect is really on the conjunctiva. It's almost like a little crater on the conjunctiva. So it's important to know the difference between actual tube exposure or tube erosion versus conjunctiva dehiscence or retraction or erosion. So I think it's important to distinguish these two now. That's not to say, if we leave this erosion alone, can this cause more friction or breaking point over the donor sclera and thin it out? I think that's still a concern in this scenario. So for this case, the first approach I took was I stopped the steroid. I lubricated the surface better with a preservative-free artificial tear hydrosense here every 2 hours when awake. So this is made of sodium hyaluronate 0.15%. But there was no change after 3 days. So maybe I'll ask my panelists again, what you would do next. And maybe I'll pull Josh into the loop as well. Definitely value a cornea and anterior segment surgeon's opinion in dealing with these kind of scenarios.
Great, thanks. Yeah, I am lucky that I don't see a ton of these, but when they come to me, they're often pretty bad. So they are tube erosions usually. At this point, I would have done the same thing you did. Now, of course, I'm not a glaucoma surgeon like you mentioned, so I don't want to damage your nice tube surgery, but I generally would have reduced the steroid and made sure they're really well lubricated and make sure that there's nothing rubbing. And then, of course, you want to make sure that there's nothing under tension. Conjunctiva likes to be vascularized and not under tension. So here, if you've done that, and it hasn't really helped, I'd probably say if you are looking at surgery, you might want to start thinking about how much tension do you have. I think generally, amniotic membrane has a role in certain conditions. I think it is overused, but I think that it has a great job when its job is to help other tissue repair, not to use it as a tissue that's going to provide any type of structural support. What I would probably, if I'm going to go to the operating room, I generally want to go once. I don't want to go 6 or 7 times and do a little bit more. So I would probably have amniotic membrane ready. And when I go in, I would see, if there's any tension, I would want to bring the conjunctiva, make sure it is freely mobile and get a good closure. Sometimes a little bit of inflammation is actually good. So if you want inflammation, you can actually tack in a few extra vicryl sutures, and that actually brings in blood vessels and inflammation. If you don't want inflammation, obviously you use nylon sutures. And I would sort of start with just a good mobilization, make sure it's done. Here, I think if you wanted to use amniotic membrane to assist in the healing, it could be done. That would sort of be my step. I would also make sure, and it looks like the erosion here is directly in the center of your scleral patch graft, which to me means it could be under tension or rubbing, because if it was on the edge, you'd know it'd be rubbing, but as it's on the center, that to me is more of a central pressure. So it's sort of the location would make me sort of decide how I would fully treat it. And of course, like when you're in there, it would really help to see how the tissue behaves, and that would give me a good idea of what to do next.
Yeah, that's great. How about you, Matt? Would you take this case to the operating room at day 6 after surgery, seeing this?
Yeah. So a few comments. The first thing I'm going to assess is the eye pressure, chamber stability, and the retina. I'm a little more worried if this is Seidel positive and we are having instability of the anterior chamber, or or choroidals. The next step is to get a better sense of what the cause is. So this has already been alluded to. If I'm having a difficult closure in a patient, I actually sometimes leave the limbal aspect of my donor sclera bare on purpose, because I would rather hang it back a little bit and have good vascularity and a good closure more posteriorly and let that area granulate over, as opposed to trying to stretch it too much, get some buttonholes more posterior, and then really have no conj to work with at the end of the day. It ends up being like suturing the socks, I think, that you alluded to. So if I'd done this surgery and I knew that I maybe stretched it a little more than I wanted and I had a buttonhole and this was very much a mechanical issue, I wouldn't be very worried at all, to be honest, assuming again that the eye is okay. I would definitely not be using NSAIDs at this point. I probably wouldn't stop the steroids altogether, though I would aggressively decrease them, though I'm assuming if you're presenting this case that, you know, things are potentially going to get worse. But I could tell you in the early stages, I would still have them on steroids because I'm still thinking long term. I don't want my tube shunt to fail. There's a bit of debate about whether to use antibiotics in this setting. I would say if I don't see Seidel, I probably would not use antibiotics, to be honest. I don't want to put anything else into the eye that could be causing more toxicity to the surface. And then something else, and our cornea specialists are much better at this than me, but I would be thinking about my ocular surface as well. And this is something that we try to optimize beforehand, but definitely in a situation like this, where we're trying to have as much healing as possible. And I would especially say that if we thought this was more of a melt situation, that's where I'd really be, you know, that's where they'd be getting, you know, oral doxycycline in my hands and you know, warm compresses day and night. And I know I can always rely on my cornea colleagues as well if I'm having trouble. So I think the short answer is I would not be thinking about going surgically here. Both, if I think it's a mechanical issue, I probably wouldn't. And if it was a melt, I think those are very hard to deal with surgically.
Yeah, be careful with the steroids. I mean, I think intuitively, you know, people want to reduce them, but in this case, when it's retracting like that, you've got some cicatrization of tissue, you've got some contracture of tissue. And if anything, you want to aggressively treat inflammation and proliferation of fibroblasts. So not only for the long-term potential blood preservation, but more importantly, I think for the early, you know, retraction of tissue, which I think you want to address. I think that's important. And I think, you know, sometimes what I've done, actually, I've even done a relaxing incision at the slit lamp if I feel there's aggressive contracture, retraction posteriorly, just to kind of address that as much as I can, because those things will continue to retract. It'll retract, and then it becomes hard to repair, of course.
Great, yeah, thanks for everyone's comments. So I'm gonna argue a little bit more towards not doing any procedure. So I'll show what worked for me and kind of introduce a little algorithm that I've developed. So for this case, I actually changed her HydroSense to Thallos Duo and Ocunox. So we know the Ocunox comes in an ointment form, applied at bedtime mostly, and the Thallos Duo is hourly when awake from lactation thea. So with Thallos Duo, we know that it's made of also sodium hyaluronate 0.15%, just like HydroSense, with the addition of trehalose 3%. So we know that hyaluronic acid actually promotes epithelial cell migration. So CD44 is actually a hyaluronate receptor, not just on cornea, but also on conjunctival epithelium. That's important for cell migration. And trehalose actually helps suppress some of the apoptosis and inflammatory markers like MMP expression on the conjunctiva. So with Ocunox ointment, we know it's contained vitamin A. We know that with vitamin A deficiency, there's decreased goblet cell on the conjunctiva, and it's been shown that if vitamin A is applied topically, it can increase goblet cells density in the conjunctiva at 3 and 6 months. So this is what happened to her. You can see at 2 weeks after changing the course of the lubrication, there's some more vascularity over that pressure point, and there's no more uptake of fluorescein. And just comparing, you know, side by side before and after, how it looks on a slit lamp and with the fluorescein. Now, so this worked out very well for her, but I also have some cases where, you know, this doesn't do the trick. If there's been no change after lubrication, you know, as some of the things that Matt had already pointed out. So this is when I would move on to the oral therapy. So this is kind of a regimen I've learned from Dr. Rukia Mather when I was a resident at Western, kind of stealing some ideas from our cornea colleagues. So doxycycline, 100 milligrams orally twice a day. Vitamin C would be pretty high dose, 1 gram twice a day to 3 a day, and then omega-3 supplements. Now we know that doxycycline works by inhibiting MMP and also inhibits tissue necrosis factor alpha. This is a case report from India showing how, exactly as I pointed out earlier, this is true retraction. So you can see the conjunctiva actually pulls back from the limbus, and this happens at day 5. And the patient got switched to oral doxycycline while maintaining on steroid drops. As I pointed out, there's definitely some kind of inflammatory component here. So you can see from the figure that at even like 15 days, there's some improvement onwards to 3 months. And we know that vitamin C is an antioxidant. It increases also goblet cell density. And omega-3 together with vitamin C also showed reduction in squamous cell anomalies in terms of metaplasia. So this is a case series that I've looking into my EMR, patients where I've tried just medical approach, not touching it with any suture or relaxing incision, how it behaves with lubrication plus the oral supplements. And you can see from the duration side on the right side, a lot of these would kind of go away at around 1 month. I've had an 89-year-old, you can see that requires this all the way to 3 months. The bottom one is kind of tricky. It was actually a patient with uveitic glaucoma, recurrent tube exposure, had 2 times donor scleral patch grafts and autograft of the conjunctiva. And then eventually right after the second repair, 3 weeks later, the conj was leaking. So there was no obvious erosion or exposure, but the conj was just oozing. So what stopped it was doxycycline and a combo with vitamin C and omega-3. And this patient actually kept on the therapy ongoing for more than a year, but at a reduced dosing of doxy. Now, one can also argue this sometimes doesn't work. And I've also had patients where we've tried the medical supplement and it's still not healing that epi defect. So for these patients, I try autologous serum, and I find that it actually works very well. I don't know if, from the cornea standpoint, maybe I'll ask Josh, how often would you be using autologous serum for like not necessarily dry eyes or ocular surface disease, but like a posterior or limbal stem cell transplant kind of setting? Do you find there's significant improvement if you move on to trying like autologous serum or any role?
So yeah, I probably prescribe it every week or every other week at the very least. I use it quite a bit. Yeah, obviously dry eye, just due to the sheer volume of dry eye patients, is the most common reason. I wouldn't use it after like a regular pterygium or anything like that, but I think for me, it really falls to neurotrophic ulcers is probably one of the most common reasons that aren't dry eye that I use it, if not the most common. And then other than that, limbal stem cell would be another one. So I think that it has a great safety profile. I mean, it's basically like there's really no problems that I've ever seen from it, although you could argue there are a few. And the one thing is it can be tricky for some people to get. Like we're very lucky that we can get it quite simply, but it can be tricky for other people. And I think that it's a great thing if they can get it quickly. So I find that often for me, just where we practice, the pharmacy that we work with, they require negative serology for certain things, HIV, hepatitis B, C, and syphilis. And to get those, most of those in Ontario are done through public health. So the turnaround isn't super quick often, but if you can try to expedite that and get them in quickly, you can get the drops quickly. So I think, often when you're not using this for dry eye in a time sensitive manner, it can be a little tricky to get this quickly, but I find it's extremely helpful for any ocular surface disease.
Yeah, so I put this kind of later in the algorithm exactly for the reasons you've mentioned. I think accessibility is a problem. Cost is also an issue. I put a range there. It's basically for 3 to 6 months supply, but it does work very well. It contains vitamin A, just like Ocunox, promotes growth factor-rich environments with epidermal growth factor, transforming growth factor beta. So there was this study from Japan that actually looked at using autologous serum to seal up aqueous oozing or transconjunctival oozing from avascular blebs. And it seemed to work very well at even 20% concentration used at QID for a 3-month period. At this dosage, the oozing stopped in more half of the eyes through the avascular bleb, but it didn't stop any point leaks. But that being said, we're not sure if a high concentration may be an option. So this is kind of my algorithm in dealing with these situations, conjunctival retraction or erosion post-tube. I tend to, as we pointed out earlier, increase or maximize lubrication first. Try to reduce exposure to preservatives. If that doesn't work, then I move on to more systemic therapy, knowing that there's some side effects that can come with doxycycline, like GI intolerance. And then if need be, go on for the autologous serum, in which case it's harder to get, more expensive. But you can see it actually works very well. This is another case series I looked into where I've tried even doxy and tears and vitamin C omega-3. And if it doesn't work, I move on to the serum. And again, I make these stepwise moves pretty fast. So if I try one thing and it's not working for a week, then I switch it immediately to the next step. So you can see most of them resolve at around a month. There was a neovascular glaucoma patient that required it ongoing for 4 months. And I think there was some uveitic component to that as well. And then the very last in the list was an 89-year-old patient. So it took 4 months also to get rid of it. And again, this patient presented with tube exposure. Interestingly, it happened at 6 months after the tube shunt, and it happened 1 week after she got Eylea injection for BRVO. So I wasn't sure if it was because of mechanical trauma from the speculum, or we also know that povidone iodine can cause a little bit of trauma, micro trauma to the conjunctiva as well. Knowing that she already had underlying ocular surface disease, perhaps this kind of tipped over the edge. So after the patch graft and conch pull down repair, 3 days later there was the conch defect again. So for her, I didn't go through the pathway. I just went straight to the bottom. I went straight to autologous serum Ocunox and adding doxy, and that basically over a slow 4-month period of slowly tapering autologous serum, it sealed off the conjunctival defect and didn't come back. So we've talked about risk factors. Certainly the risk factor is different if we're talking about like tube erosion per se with thinning of the donor sclera, but I think a lot of these a common factor is inflammation. So ocular inflammation and systemic inflammatory conditions tend to associate with this. If the patient had previous conjunctival surgery or chronic glaucoma medication use that compromises the integrity of the conjunctiva, or very bad ocular surface disease. These can all play a role in affecting the outcome of post-tube conjunctiva integrity. And incidence tend to be under 5%. And it seems that the model of the implant or the tube shunt doesn't really matter. There hasn't been any difference from reports about how often this happens with Ahmed versus Bevelt. The hypothesis why inferior tend to happen more than superior conjunctiva seem to be that inferior conjunctiva have a smaller recess, so there may be less conjunctiva for us to work with. But there's no consensus about how often this can happen to the different types of patch grafts we use. It can be irradiated pericardium, cornea, sclera. There's no significant difference reported. But prevention is key. I think if we close these kind of periotomies, if we're more aware of how well we tack down the tenons, then we put down the conch, it can improve the tissue integrity after we put on the donor sclera. We want to avoid excessive mitomycin or 5-FU exposure after trabeculectomy in these cases to prevent future erosion if we are to do tube shunts. I haven't tried scleral tunnel technique for these kind of for tube shunts. I know there's been some studies that talked about how if we not even use any patch graft material and just do the scleral tunnel technique, that it may avoid having a raised profile that can cause a pressure or friction point. Now, is anyone in the panel in the audience familiar with the scleral tunnel technique for tube shunts? Now, personally, I haven't tried it. I feel, at least in my hands, I couldn't get that angle very well of, trying to get the angle into iris plane upon entry into the anterior chamber. But maybe I'll ask, Matt, Jab, and Ike, what are your thoughts about using scleral tunnel rather than any patch graft material for tube shunts? Any pros and cons?
Maybe we'll get the panel group, and I think Mariam's here too, so I'd be interested in Mariam's thoughts. We've been doing it for some time now, but I think it'd be great to get Matt and Jeb to comment, and maybe Mariam then.
Yeah, I'll just say, so my current go-to technique is to do a 3 to 4 millimeter scleral tunnel, and then go into the anterior chamber and sometimes in the sulcus for my cornea patients. And then I also put the donor sclera over there. Now, keep in mind, my practice population is heavily weighted towards patients with significant comorbidity, particularly on the ocular surface side. The time that I will do more like a 7 or an 8 millimeter tunnel is in the setting of the choroidal autografts, for instance, the Cincinnati method, where they have some type of graft at their limbus that I'm trying to avoid. I find when I make a 7 millimeter tunnel, and I know other people feel otherwise, that there's always an upward bias in terms of the tube pointing towards the endothelium. I often do these ones in the sulcus. So when I do in the sulcus, I have a little bit more leeway, but then I know that the tube is kind of up against the iris as well. My other comment is, in the setting of uveitis, I have seen some of my uveitis patients melt completely through a thick scleral graft. So I'm quite worried that if I were to just do a scleral tunnel, that they would easily melt through that. Like just looking at that first patient that you shared, if there was not that scleral graft there, I would be much more concerned. The one setting where I do consider doing it is in younger patients with good conjunctiva, where I'm doing an inferior tube. And this is related, I tell the patients I'm not a cosmetic surgeon as a glaucoma specialist, but I do have a few patients who are quite bothered by the appearance of the scleral graft inferiorly. So I can have that discussion with the patient, the risks and benefits. And again, if they have good conjunctiva, I would consider doing it, though I still have that scleral graft just in case, because as you said, the inferior are higher risk of erosion. And if there's any concern during the surgery, I would still put it on.
Yeah, so my usual technique is we're typically doing about a 4 millimeter scleral tunnel. And a lot of times we're not even using donor sclera. Some will say that, if you're particularly worried about corneal endothelial health, then maybe you can bypass the scleral tunnel and go ahead with the donor sclera. Because there is a bit of a learning curve, you're right. It tends to have a bit more of an upward bias, as Matt was saying.
How about you, Maureen?
So I do, recently I started doing short scleral tunnel. I don't do 7-8 millimeter, it's very short. At the same time, I do sclera patch graft as well. So I do both, but my tunnels are not really long. Especially when I started, it happened that my tube was pointing toward endothelium. It was hard at the beginning. Now I'm getting better, but still at the same time, tunnel plus patch graft. I do both.
Okay.
Yeah, there's a question here about the tube insertion technique. I don't know, Ike, do you want to comment on yours, or you want me to comment on doing the tunnel?
Go ahead. I mean, I think most of us have really taken Felix Hill's approach from Mexico with the sort of the 3.5 millimeter scleral tunnel, although others vary as well. But you go ahead, Matt, if you want to answer that one.
Yeah. So before I start mine, I want to identify where I believe scleral spur is, and again, that's sometimes problematic in these patients. And then I'm going to start 3.5, maybe even 4 millimeters back. I'm going to start, my bevel's up, and I'm tunneling just in the sclera until I hit the scleral spur. And then if you just keep on going with that trajectory, that's where, unfortunately, it seems like you get that upward bias. So as soon as I hit scleral spur, I actually, I'm telling fellows, point towards the nerve. And you want to go, I would bias more than iris plane. And I've always been tricked. I always think, oh, I went deep enough. And it turns out that you still have that upward bias. The other thing is, when I'm making my scleral tunnel, I'm pulling up a little bit, because it really helps me to establish that plane. And then when I'm going in, again, back to the nerve, and even so that you may brush up against the iris while you hit the anterior chamber. And again, if you're worried you're making a scleral tunnel, you could consider going into the sulcus in that setting.
Great. So yeah, thanks everyone for your input. I think yeah, no cool surgical video for my talk, but just want to go over a little algorithm that I've had in dealing with these kind of scenarios. I think a lot of these cases, if we catch them early, medical therapy can be sufficient, but it's got it done right. Autologous serum may be the ideal for these in terms of healing and helping the conjunctiva to fibrose over, but we know accessibility is not always available, and there's also a cost component to it. So thanks everyone.
Thank you very much, Toby. That was great. I think we had 3 great presentations today and great panel discussions. I'll put up your next slide, Jeb, just to kind of talk about the next rounds we're going to do. And there's just a few little questions that have come up. And thank you again for the panelists for answering back about doxy. I think doxy, of course, which impacts MMP regulation, I think is an important piece to this. I think you've written some doses here, which I think came up in some of the questions here. And so I want to thank everybody for your questions that have come up. I guess I don't know if I don't think Guillermo's still on, is he? No, Guillermo's. I think Guillermo's still there.
I am.
Okay.
Yes.
Yeah, great.
I have to go in about 2 minutes, but that's fine. Yeah,
no problem. I guess there were some questions that I think already kind of got asked about posterior rhexis in terms of decision making, in terms of hydration. So I think we answered those as well.
Yeah.
Oh yeah, question came up. What about a one-piece lens? Can you? I think somebody asked. Can you optic capture through the posterior optic buttonhole technique a one-piece lens? Would you have a person who has a high cylinder toric, for example?
Mm-hmm. Yeah, I have done that as well. My preference is the 3-piece lens, but with the single piece lens platform, that's actually how I got into this technique, and it was mostly in kids years ago, and that's how I did it initially. So it can be done. What I would recommend in that case is to do it in stages. So insert the lens in the anterior chamber and then gently nudge each haptic inside that space that has been created between the leaflets.
Yeah, I agree. I've had a lot of experience with one-piece lenses, and I use them if they need a toric. If they don't need a toric, a 3-piece lens is definitely easier.
Mm-hmm.
And that's where sizing of the rhexis is going to be important, because if it is too small, then you start getting torquing of the thick haptics.
Exactly.
That can potentially destabilize the lens. And of course, remember, we're talking about putting the IOL in the bag and putting the optic behind. So you really want to get that rhexis just really perfectly about 4.5 millimeters. I think would be the ideal size for that case. So I think it can be done. And I think that the the stability is excellent. Of course, there's really no issue about rotation for these lenses when you do a toric optic captured. Exactly. So thanks for everybody for joining. We had
thank you
about 380 people. I think I saw at one time, and we still have about 250 now, which is great. It's been great to have a discussion. We're gonna, I think, continue doing this on our Saturday at noon and Wednesdays at 3. And as Jeb said, I think we have some cool cases. I'm not sure what the first case is, enforcing iridocorneal distancing. So that'll be an interesting topic. But we do have some cool cases from Steve Safran talking about difficult IOLs and should we be removing them? Should we reposition them? What should we do with them? And also we have a talk from Jordy, who's going to talk about issues around dealing with the post-cataract after vitrectomies. And maybe we'll get him to chime in. It'll be good to keep Steve Safran in check with a VR surgeon. So I've asked Jordy to join us and talk about that as well. So keep your comments coming. If any of you are interested in being a panelist, please let us know. I think Jeb had the email address up there as well. And wishing everyone again a safe weekend. It's pretty nice and balmy warm here in Toronto. So stay home still, of course. I shouldn't say that. Stay home. Or if you go for a walk, stay at your distance. Thank you again, everybody. Thank you for the panelists. Appreciate the ones that we had come on, and we appreciate the ones we added in as well. So thank you very much. We will see you again in a few days.
Thank you, everyone.
So
it was great.
Thanks very much.
Thanks.